Let us move on to the next talk. Actually, next speaker is not available. That's why we will move on to the next speaker. Dr. Himabindu will be delivering her talk on medical management of glaucoma.
Good morning, everyone. So I'll be talking about medical management of glaucoma. We all know that glaucoma is a progressive optic neuropathy, and we are all aware that whatever damage occurs in glaucoma is irreversible. So when we are treating a patient, what we are trying to do is we are trying to preserve whatever healthy nerve fibers are left so that we can preserve the visual function and delay the disease progression. All this by maintaining the quality of life of the patient. So how do we do that? We do that by reducing the intraocular pressure. Intraocular pressure is the only risk factor whose manipulation has shown to alter the glaucoma progression. So that is the only thing we can aim at. So when we see a patient, we look at what is the initial pressures, initial presenting pressures of the patient, what is the extent of disease in the eye, how much damage is there, what are the comorbidities, is there a strong family history. So depending on all these factors, we arrive at what is called target intraocular pressure. So to achieve the target intraocular pressure, we either give them medical management, surgical treatment, or laser treatments. So intraocular pressure is elevated basically because of reduced aqueous outflow due to functional or structural abnormalities. So when we are treating glaucoma, we treat the mechanism. That is, we remove the precipitating factors. If there are any factors which are causing raised intraocular pressure, try to withdraw that. Reduce the intraocular pressure, correct the abnormal anatomy. If there is secondary glaucoma, then you treat the underlying pathology. And if there are any associated systemic problems, you can consider treating them as well. And medical treatment is very effective in majority of the patients, and it is widely available. We have an armamentarium of anti-glaucoma medications which are quite effective and patient-friendly nowadays. Only thing we have to remember is it requires good compliance from the side of the patient and his family. And the choice of medicine, as I told you, depends on mechanism of glaucoma, comorbidities, and risk factors. When I see a patient with angle closure glaucoma, what I do is I do a AIOCMTC2 and then treat in the lines of primary open angle glaucoma itself. So we have all these kinds of medications which are available in the market now: prostaglandin analogs, beta blockers, alpha agonists, carbonic anhydrase inhibitors, cholinergics, hyperosmotic agents, and most importantly, fixed drug combinations. After the advent of fixed drug combinations, it has become very easy for the patient to administer them, and even for the ophthalmologist to prescribe medication, more of adherence to the medication is there after fixed drug combination has come in. Although there are, some people think that when you have a fixed drug, maybe the drugs may not act as well as they are given individually. But that's okay, because the number of instillations comes down, adherence increases, and even exposure to the preservative also decreases with the less number of drops. So I kind of like fixed drug combinations. So how do these medications actually work in glaucoma? They either increase the aqueous outflow or they decrease the aqueous production. So it all started with beta blockers and myotics. In my undergraduation and early post-graduation, this was what I have seen many doctors prescribe: beta blockers, timolol, and myotics, pilocarpine. So beta blockers were good because they were giving around 20-25% reduction in intraocular pressure with a dosage of 2 times a day. It was convenient for the patient. It was economic for the patient. Coming to the myotics, that is also a good drug. It actually causes constriction of the pupil. It stretches the iris and increases the trabecular meshwork spaces, thereby increasing the aqueous outflow. But the problem with the myotics was the dosage was 3 to 4 times in a day. And then because of miosis, if the patient had developed cataract, there was early visual dampening, and it was difficult for the patient also to do surgery in myotic pupils. And there was brow ache, and also beta blockers was a better medication at that time. Beta blockers, even now nowadays also we use in the treatment. Pilocarpine, though it is used only in particular conditions like Plateau iris syndrome, or where you have given maximum medical therapy and you still want some more reduction, you can't go in for a surgery, then you can try pilocarpine. And to do AIOCMTC2, definitely we use pilocarpine. Then came in adrenergic agonists and carbonic anhydrase inhibitors. So they were introduced as second line of medication, and the dosage was 3 times in a day. They were giving around 15 to 20% reduction in intraocular pressure. So they were good when given in with beta blockers. So that went on for some time. Then came the prostaglandins. Prostaglandins were definitely wonder drugs because their pressure reduction was almost 30 to 35%. So I was first introduced to a molecule called latoprost. Latoprost was bringing down the pressure very well, but the problem was it was pretty expensive for those times. Even if they had an offer like 1+1 offer, still at those times it was considered expensive and it needed a cold chain to maintain. So it did not probably become that popular. Then came in the bimetoprost, which was good, which was very effectively reducing the intraocular pressure, but the problem was a lot of ocular side effects. A lot of hyperemia, eyelid pigmentation, eyelash growth and all. Patients were finding it very difficult to accept the drug, and even as ophthalmologists, we were finding it difficult to give that. That was when it was 0.03%. Then around 2006 or so, travoprost came in. And travoprost was very good. It was my first line of, first choice for a long time, because it was bringing down the pressure well with only 1 instillation during the night time and not much ocular side effects. And they came in with what was called endurance. So the patient was, even if the patient has little difficulty in administering the drop at the same time, still the IOP was maintained. There was no peak and troughs. So as I was telling the side effects, I will not tell much about it. One thing what I want to tell is, when you see a patient, when you initially see a patient, depending on the intraocular pressure, and depending on the target IOP that you have decided, what you should do is you should prescribe one medication which has the greatest chance of reaching the target pressure with best safety and tolerability profile, minimum inconvenience, which is affordable, and maximal likelihood of adherence. So minimal concentration and minimal frequency. Start with that. So once you have given a drug, call back the patient after a week or 10 days and see if the IOP reduction is according to what you have thought. You know the prostaglandins bring down the pressure by 30%. So if the pressure reduction is according to what we expect, but still it has not reached the target pressure, then you can add one more drug. But if the pressure reduction is not as much as you expected out of the drug, then you switch to another drug rather than going on adding medication. You can even switch to a different prostaglandin. Sometimes that prostaglandin might not work. Some other prostaglandin might work for that patient. Still it is not coming, then you can add one more medication. Do not combine 2 drugs with same pharmacological actions. Do not use 2 fixed drug combinations with overlapping categories. Sometimes when the initial pressure is very high, that is above 40, then you can start them on more than one medication initially itself. So you have to make sure that the patient is compliant. Talk to the patient and the family members, explain to them the prognosis of the disease and importance of using medication. You can ask them to, keep some reminder systems, like in the mobile they can have an alarm or so. My time is over, I guess, sorry. About the newer drugs, Shailija will be speaking. Just want to summarize by telling that prostaglandin analogs are the first line of therapy, followed by beta blockers in POAG. Alpha agonists and CIA inhibitors are the second line of therapy. Neuroprotective agents are still under trial, and there are newer drug delivery systems to enhance the adherence and ease of instilling the medication. Thank you very much.